So we're going to talk about environmental disorders. One of the great things about emergency medicine, and Kevin mentioned we're approaching our 50th year, we're still actually the newest specialty, core specialty in the House of Medicine, despite us having existed for 50 years. One thing, as we sort of defined what we do in emergency medicine, we embraced a lot of the nooks and crannies of medicine that hadn't really been claimed. And I kind of think environmental disorders is one of those things. These are all the emergencies that happen to us in our environment: heat illness, exposure to temperature, all the toxicology stuff, electrical injuries, these kinds of things. And I find it one of the more interesting areas of what we do in emergency medicine. It's a real potpourri of topics. But as we started in emergency medicine, we also grabbed things like hyperbarics and toxicology and all these we invented EMS. So many interesting areas of practice in what we do. So I find this talk to be really fun. Many of you work at altitude or in cold temperatures or hot places, and you know a lot about treating these types of patients. One thing I'll say is that a lot of the recommendations that go with treating environmental disorders are not heavily evidence-based. You'll find that there's not a lot of research, powerful research in these areas, but it turns out that a lot of the research in these areas is now being done by emergency medicine. There are wilderness medicine fellowships where we do a lot of this type of research. So pretty fascinating stuff. This is going to be a flyby of a lot of different types of topics, some of which, as I mentioned, many of you know a lot about. So let's start with altitude illness and what happens to our body as we ascend in altitude. So as we go up on our planet and we have decreased oxygen tension, things happen physiologically in our body and we get effects of that. So as we go up and we have less oxygen, our body starts to crank into sympathetic mode. Our heart starts beating faster, we're compensating for less oxygen molecules coming in. And one of the things that happens at a micro level is we start to experience capillary leak. And that explains a lot of the symptoms that we see in patients who ascend in altitude and start to have problems. One of the things that's interesting about altitude illness is it doesn't matter how in shape you are. Being fit is not protective for altitude illness. And we know this from stories of mountain climbers who are, one of the fittest species of people on the planet. This can really happen to anyone because this is really at a microscopic physiologic level. It has nothing to do with your level of fitness. Certainly you can acclimate, we know that, but being fit is not protective. So a lot of these types of environmental illnesses, altitude illness included, really exist over a spectrum of illness. There are mild forms of this, and there are really life-threatening forms of this. The mild form of altitude illness, probably many of us in the room have experienced, which is really acute mountain sickness, which is basically the hangover type feeling you get when you really ascend to altitude, where you feel a headache and a nausea, and you don't sleep very well, that kind of thing. And this usually starts to occur at about 8,000 feet or higher. This can vary from person to person, but it starts early. Pretty much as soon as you get there, you can start feeling symptoms. And again, I equate it to sort of a hangover. It's sort of like a hangover. It's worse if you've been drinking. It's worse if you have any sedatives on board. And there is something you can do about it. For all of the altitude illnesses, the ultimate answer is to descend back down to sea level. That's where you'll feel better. But in terms of what you can do when you're there, one of the things in terms of acute mountain sickness is to use this drug acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor. The trade name is Diamox, and it can help these symptoms. And it does it by creating a metabolic acidosis in the body, which then we compensate for with a respiratory alkalosis, which drives our ventilation. It increases our ventilation, which is going to help with that oxygen intake, and it really does make you feel better. It has some weird side effects if you've ever tried acetazolamide. It makes your extremities feel tingly, and it also, because it's a carbonic anhydrase inhibitor, it makes any carbonated beverages, all the bubbles go away. So things taste flat. Any kind of carbonated soda tastes flat. Things taste a little weird. So you have to tell patients about those side effects. The truth is about acute mountain sickness is usually self-limited. That will go away in the first few days that you're there. You will start to feel better, and you can also treat the headache with NSAIDs. Steroids can be of very limited value, but they're on the list. Oxygen can help, of course, oxygen supplementation. And again, the ultimate treatment for any of these altitude illnesses will be descent. As we get into the more life-threatening part of the spectrum, we talk about cerebral edema and pulmonary edema. And as I mentioned, part of the pathophysiology of altitude illness is capillary leak. And this is where this really kind of ramps up in terms of cerebral edema, pulmonary edema, those organs that can be really life-threatening. So as the capillary leak starts to happen in the CNS, we start to see people have altered mental status, things like seizures. These things can occur at altitude, and it's a really, really big deal. Ataxia, not walking properly, vomiting. And again, ultimate treatment is descent. We can use things like a Gamow bag. We can sort of deal with the pressure itself. We can use steroids, mannitol, hyperbarics, that's a Gamow bag. But really, descent is the ultimate answer for this very life-threatening condition. In terms of high-altitude pulmonary edema, as you get that capillary leak in your lungs, it can start with a cough, can start with trouble breathing, and this is really the most lethal of these altitude illnesses. And often people do start with acute mountain sickness and progress to this, and it usually happens after they've been at altitude for a little bit, and they start to have actually pulmonary edema. This is one of the things on the list of non-cardiogenic pulmonary edema, meaning that if I did a chest x-ray on this patient, it's not going to be like a CHF type of pulmonary edema. They're not going to have a big heart, cardiomegaly. This is going to be a normal-sized heart with pulmonary edema, and there are a few things that can cause that, and one of those things is high-altitude pulmonary edema, and you really need to get people down in this particular condition. Let's move on to a kind of an accompanying topic, which is hypothermia, what happens to our bodies at hypothermia and how we should be dealing with it. So technically, if we want to call someone hypothermic, they have to meet these criteria in terms of where their temperature falls. One thing that's a misperception about hypothermia, and many of us who work in urban areas know this doesn't just happen in cold places. This happens even in urban areas, urban hypothermia, when people are exposed at not particularly low temperatures, but aren't doing the things that they need to do to get their body warm for special reasons, things like alcohol intoxication, et cetera. One thing about treating patients with hypothermia, and this can also happen in sepsis, right? There are conditions that we have where we also see hypothermia. This is really actually exposure hypothermia that we're talking about, is that thermometers, many of the thermometers that we use in our emergency departments have sort of lower limits where they don't go below a certain number. So you have to make sure that you're getting accurate readings when you're treating a patient with hypothermia that go below a certain level. And you want to also get core temperatures, not peripheral temperatures. So you want a rectal temperature or a bladder temperature. Many Foleys, when you insert them, will give you an ongoing bladder temperature. That's the most common way that we do it. Esophageal temperatures, less done, but possible. Certainly the risk factors for these include extremes of age, again, in conditions where people can't sort of deal with the compensatory mechanisms that their body is telling them to do, altered sensorium, people with burns, trauma, we can see this again in sepsis, etc. And often people can be altered, and commonly they are bradycardic in terms of their vital signs. There are some interesting findings on the EKG in patients who have severe hypothermia. This is one of them. It is not pathognomonic for hypothermia. You can see Osborne J waves in other situations. Right at the end of the QRX complex where the ST segment starts to take off, that's called the J point. And right at that J point, when you have this wave where the red arrow is pointing to, that's called an Osborne J wave. And you can see that in some other conditions, but it's one of the interesting findings that you can see in hypothermia, usually again in the setting of bradycardia, like this EKG. You can also see AFib, you can see slow AFib, you can see a bunch of different things in hypothermia which are quite interesting. And if you remember from your ACLS protocols, in hypothermic patients, the cardiac muscle is very irritable. So there's particular things that we do to take care of that heart in hypothermic patients. So we want to warm people up. That is common sense. How do we do that? Well, there's lots of different ways to warm people up. There's passive rewarming, there's active rewarming, and certainly warm blankets, that's a really good way to start, getting off any wet clothes, but using radiant heaters, hot water bottles, warming the fluids that you're giving patients, those are all really important things. If people are critically ill from hypothermia, there are more active things you can do, like warm bladder irrigation, warm NG tube lavage, if you do an NG tube and do a stomach lavage with warm fluids. Those are things that you can do as well if you want to do core warming more quickly. You can even go as far as putting in chest tubes and doing warm intracavitary lung, warm water lavage as well. Those are on the list of people who are critically ill, door of death, that we're trying to rewarm. One thing to know is that as you rewarm people, it's really common that you get this paradoxical afterdrop. As you start to warm people, you have to look for this afterdrop. As the peripheral blood, which has been cold, really starts to circulate, you will often get a dip down in temperature as you're in the process of rewarming. Warm humidified oxygen is also on the list. Now, certainly frostbite can happen at cold temperatures, and one way to think about frostbite is really kind of burns from the exposure of cold temperatures, because really, like burns, you can characterize frostbite in terms of the thickness that it's involved, the superficial down to the dermis, etc. There's first degree, second degree, depending on how far down the tissue damage has occurred. One of the things to know about frostbite, and this is frequently asked on board exams for emergency medicine, is about how you treat frostbite. And one of the key things is that you want to rapidly rewarm that extremity, and you don't want to do it at any point where there's a risk of it refreezing, because that refreezing can cause a lot of damage. So it should be rapid rewarming with warm circulating water, and do not allow any chance of refreezing. If there's a chance of that, then wait to do it until you have a situation where it will not refreeze. And we generally leave blisters alone. This can be a little bit controversial, but in general, we don't want to debride bloody blisters. We can talk about that when we talk about burns a little more. Let's move to the other side of the temperature spectrum and talk about heat illness. And again, we'll be talking about a spectrum of disease. Much heat illness occurs at the more mild spectrum of disease. But of course, we're in emergency medicine. We've got to talk about the sort of severe spectrum of the disease. There's really kind of two groups that are at risk for heat illness. There's the very young, the very old. There's a lot of different risk factors that put people at risk for heat illness. It can be medications that they're taking. It can be drugs that they're taking, et cetera. And then you have people who have the situation like when there's an epidemic heat wave and you have old people that are stuck in an apartment and don't have access to air conditioning, for example. That is one form. And then you can also have your very healthy, classically the military recruit or someone who overexerts themselves in heat, and that is another type of group that has heat illness. So we see it in different populations for different reasons. So it can happen in heat waves and in warm climates, but it can also happen on the exertion side. It doesn't have to be particularly hot outside to get that type of overexposure to heat. Now, in terms of the spectrum, there's lots of things you can see with heat. You can see heat edema, where you just get some puffiness. We don't treat that with diuretics. That will resolve on its own. You can see heat cramps. We've seen this before, certainly. People, as they cool down, they'll be fine as well. Heat syncope, as you have pooling of blood in the extremities and you have some syncope occur. And then heat exhaustion, which looks kind of like what we call the summer flu of nausea, vomiting. This is accompanied by dehydration. And we PO hydrate, cool people down, they're going to be fine. These are all generally mild parts of the spectrum. When we move over to the real emergency in heat illness, we're talking about heat stroke. And this is a real emergency. And this means that you have to combine all of this with altered mental status. And I think of heat stroke as your body is actually starting to melt. That's how I kind of conceptualize it. Things are starting to melt. Your brain is starting to melt. Your liver starts to melt. And that explains a lot of the abnormalities you'll see on the labs, et cetera, in heat stroke. Basically, you start going into organ failure from this heat exposure. And again, the core temperature is typically over 104 Fahrenheit when you're talking about sort of moving into this category. The altered mental status part of it is really important. People can also be ramping up their vital signs in terms of sympathetic overdrive. And you can see acidosis, you can see rhabdo, you can see ARDS and pulmonary edema, renal failure, hyperkalemia as the muscles start to melt in my mind. And there's really two types types of populations that this occurs in that I've mentioned. There's sort of the classic and the exertional type of heat stroke. The classic is the epidemic heat wave that happens with people stuck in their apartments without access to air conditioning, et cetera. It's not an exertional type of heat stroke. And often when you find these patients, they actually have dry skin. They're not overly sweating, they're not ramped up. And you don't typically see a lot of renal failure and rhabdo in these types of exposures. But these patients do often have a very difficult time physiologically coping with the exposure to heat. On the other side, you see the isolated case of the person who's overdone it, who's exerted themselves too much, who's often healthy and active, and may be sweating quite a bit to try to compensate. They may also have diarrhea. This is often seen sometimes at the end of like a marathon or some overly exertional type of activity. And you can, in these patients, see DIC and renal failure and rhabdo, et cetera. That's pretty common in these patients. Luckily, they're healthy. Their underlying physiology is pretty good. But the morbidity and mortality is not great in both groups. Cooling is obviously crucial. And as we guide the resuscitation, cooling has to move up to the front. Just like in hypothermia, the warming has to move to the front. It's one of the core principles in their resuscitation. So we're going to resuscitate as usual, but we need to cool them down. So what is the best way to do that? There's a lot of different ways to cool people down. Yes, you can start with ice packs in the groin and the axilla. Those are all fine. Probably one of the most effective ways to do this is to have some kind of a mister, a little sprayer. Basically get people wet and then have fans. Put fans to kind of evaporate that water, and that's a really effective way to cool people down. Again, just like with cold patients, with hot patients, we can also do active core cool down. We can do iced water gastric lavage or ice water bladder lavage if we really have a critically ill patient. Patients will start to shiver. That is part of the physiologic response. You may need to use medications to control that shivering because you're kind of counteracting what you're trying to do. One thing you want to do as you cool people down with hyperthermia is not to overshoot, because they will keep cooling down as it's going along. So you want to stop that active cool down process when they hit around 101, which seems a little counterintuitive. They're not normal yet, I get it, but they're going to actually keep cooling down, and you don't want to overshoot. So we usually kind of stop around that point. Let's talk about burns. Burns is a really common thing that we see. We know a lot about burns in terms of the wound care. Remember that we typically used to call burns, and we still do, first degree, second degree, third degree, et cetera. But really the more accurate way to describe burns that you're seeing is the thickness of the level as to which the burn has occurred. The classic, as you start describing burns, you talk about superficial burns, which is a sunburn. That's a first degree or superficial burn. We know what those look like. We know that they're painful. You can use NSAIDs. They're going to do okay. As we start to move down in the layers of the skin into the dermis, et cetera, then we talk about superficial partial thickness burns. These are burns that look painful, they're red, they look more wet, they often have thin-walled blisters, they're often very, very painful, and in general, these will typically heal in a week or 2 weeks with good wound care without much in the way of scarring. As we start to move deeper into the levels of the skin, we start moving into the deep partial thickness area. And this is when we've gotten down to dermis. These are also painful. They can have areas that are red and white. They can look sort of mottled. They have sort of thicker walled blisters, indicating that we're a little bit deeper. And they may have areas that are kind of have a slight decrease in sensation. And these are ones that are more at risk for scarring. We're getting into that area where pigment changes can occur. It's going to take longer to heal, may need a graft, et cetera. And then certainly full thickness burns. You're down to deeper tissues, which is often actually painless because you've burned through the nerve roots. You have the white and brown areas. It's often very dry looking, and they don't often have sensation there. This is going to definitely need grafting. So a better way is to just describe those levels of thickness of burn when you're talking to a consultant, et cetera, and describing it in your chart as well. In terms of estimating body surface area, there's a lot of different ways to do this. There's lots of charts that you can use that give you different estimates. This chart here with the body shapes gives you what we call the rule of nines, where you divide the different parts of the body into sort of areas that equate with 9. That's one way to remember the rule of nines, that one half of your body is 18%, the two different nines, the back is 18%, et cetera. The patient's palm also is approximately 1% of their body surface area, so you can use that size of the palm to also estimate. Usually we're estimating not the first degree burns, we're estimating the sort of superficial, the deep partial thickness, the more serious burns is really what you're estimating when you're talking about what percent body surface area is burned. For children, obviously the proportions are different. There's what's called the Lund-Browder chart. You're not going to remember all of these numbers, but certainly their proportions, their heads are bigger, their torsos are smaller, so the numbers change. And so know that there's a different pediatric chart out there that you can easily look up to also get these estimates when you're estimating the percent body surface area that's burned. We see a lot of minor burns, and we do a lot of wound care for minor burns. And we know that this starts with cooling if possible, and we're going to treat the pain with our typical pain medications. In general, we recommend that you leave blisters intact if they're unruptured. They're they're the perfect biologic dressing, in fact. But if they're over joints or they're broken or they're causing pain, that's fine to debride them and clean them up. They need a tetanus update. There's a lot of different ways that you can dress these. There's a lot of different interesting biologic dressings that are available now, some that are impregnated with different antimicrobials. So there's lots of different ways to do this, but you want to do it certainly with a non-stick dressing and a clean, dry dressing with a plan for follow-up care. For patients who have suffered major burns, this is really dramatic. Some people, I work at a burn center, so we see a lot of major burns, very, very dramatic presentations, really, really tough cases. Remember that they can get hypothermic as they lose that protective layer of skin, and we really worry about airway in burns. We worry about people inhaling things and causing burns on the inside of the airway, which can rapidly turn edematous and be a very difficult airway or impossible airway to get if we wait. So we look for signs of actual airway burns. Sometimes that's done with some fiber optic scope to look inside and see if there are actually airway burns. Just because they have singed nasal hairs doesn't always mean that they have intra-airway burns. Sometimes you can have a flash burn, for example, pretty common in a lot of scenarios, which may burn nasal hairs, but they didn't actually inhale anything or have any airway burns. So you really want to take a look at that airway, but think about the fact that if you're worried about that and you need to transfer that person, we'd rather you take that airway early and not risk losing it en route to the burn center. If they had a burn exposure in an enclosed space, you have to think about the chemical aspects of that. Think about cyanide toxicity, carbon monoxide, for example, the toxicologic exposures that may have occurred in the setting of that burn. And then fluid resuscitation is a really, really big deal. There's a lot of different formulas to help you calculate how much fluid that patient needs. One of the more common ones is listed here, the Parkland's formula. And we typically use LR in these patients as a fluid for multiple reasons, and that's really the fluid of choice when we're doing really large volume resuscitation in a short period of time. And our goal is to get to good urine output, to really perfuse everything is our ultimate goal. Most minor burns we can treat as outpatients. We know how to do this, but there are certain categories of burns that should be transferred to a burn center, either in the acute period or arranged for follow-up for them to be seen at the burn center. And some of those things include circumferential burns, where you have the potential for swelling and a need for a fasciotomy. It might cut off circulation if it swells too much. Facial burns, eye burns, genital burns, these things don't heal very well, often need grafting and special wound care. Inhalation injuries, electrical injuries, and really, really large areas of burn where you really need to be taken care of in a burn ICU with proper fluid resuscitation. Most burn centers are really happy, or you may already have a protocol worked out with a burn center. They're very happy to take these calls and talk about whether or not this should be something that's transferred. And they understand that these resources are limited and concentrated in certain areas, and you have to consider whether or not this is someone you want to fly out depending on where you work, and whether or not they need that right now or can be transferred later. So these are all individual case decisions. Electrical injuries are an interesting area as well. We see these very commonly from household injuries, but also really high power lines as well. Often injuries are pretty common with big-time electrical injuries. You see the the electrician who's working up somewhere and gets a shock and then falls, not only has an electrical injury, but may have some significant trauma as well. So often these are kind of combined mechanisms. We know that alternating current, which is often what we have in our household current, is worse than direct current, because often it causes a sort of a tetanic reaction where it's difficult for the patient to let go of that source because of the alternating current. And how much injury happens from an electrical injury depends on the type of current, the duration of contact, and what tissue it passes through. We know that the biggest risk to these patients from electrical injuries is the trauma they suffer from the fall that happens, or some kind of cardiac arrhythmia that happens at the time. Think about it, it's like the ultimate defibrillation. I mean, it's a cardio version of types, and it can cause arrhythmias for sure. One of the classic burn patterns to think about, electrical injuries to think about, is the toddler who chews on a cord at home and has this burn that happens at the side of the mouth. And the reason this is particularly interesting is that right there is where the anterior labial artery runs, which is a really juicy artery. And often a clot will form quickly when it first happens. But what we worry about with this type of injury is that as the wound starts to heal and that clot starts to retract in the anterior labial artery, they are at high risk for having a rebleed happen down the road. So they need plastic surgery type follow-up and consultation. In terms of evaluating the patient with electrical injuries, we want to do a careful exam. We want to look to see where we think that path of current may have passed through. Resuscitation, of course, following our regular protocols. This again may be a trauma patient, not to lose sight of that and what we're worried about. We know that usually most people who have an average type of shock or household current exposure, they don't need extended cardiac monitoring as long as their EKG and otherwise they look good to you in the moment. They don't need to be admitted for extended observation. It's unlikely that they're going to develop a cardiac arrhythmia subsequent to their original injury. If they do have a major electrical injury, these are patients who can have a lot of damage, tissue damage inside that you can't see, which is why we monitor them for CKs and we admit them for fluid resuscitation, et cetera, because of the potential for internal tissue damage. Mammalian bites. Oh, see, we just had such a potpourri of interesting topics. People who get bit by different things, and what do we do for them? Well, we know that certainly human bite is the worst type of mammal bite that you could have. The human mouth is dirtier than any mouth. And this really applies to people who come in with wounds on their hands, right? The person that punched something, they punched the wall, and they have an open fracture, an open wound. And the concern that there might be human saliva that may have contaminated that wound. And sometimes that's not part of the original story because they don't want to talk about the assault or the fight that they had. So you have to find ways to ask that question creatively and sort of explain, if there's any chance that human saliva could have gotten contact with this wound, it would change the treatment pattern dramatically. Is there any chance that there could have happened in sort of a non-judgmental way? And sometimes you might get a different answer when they know that that's the case. But these are really high-risk wounds. They need to go to the OR for a washout and IV antibiotics. Dog bites actually have a lower infection rate than cat bites, for example, but they are more at risk for crush injury, obviously, because of the power of the jaw. So certainly when you see law enforcement canine bites, these are people who may not have dramatic external injuries, but they can have dramatic internal injuries, neurovascular injuries, fractures. They have to be looked at a little bit more closely when you're talking about a really high-powered type of canine bite. Cat bites are interesting because they're often like puncture wounds, right? They're like, cat bites are nasty. Cats are nasty, and they will get you. And that gets inoculated deep in there, and cat bites really have a pretty high rate of infection. Now, of course, there's selection bias when you talk about these types of statistics because lots of people who have cat bites don't come to the emergency department. So the ones that you're seeing are the complicated ones, which is why we say they probably have a higher rate of infection. Really, all of these bites can be well covered by amoxiclav, which is augmentin, which is the way I remember this is I remember the drug as dogmentin. Augmentin is dogmentin, and that's how I remember that's the drug I'm going to use to cover these bites is dogmentin. So there you go. Rabies is interesting, doesn't come up that often, but often people present with a concern, I need a rabies shot. Who really needs a rabies vaccine and when does that happen? Well, we know that it's very rare in the US that animals are running around with rabies. It's not zero, but it's not common. Certainly overseas, it's very common. So if you're in Thailand somewhere or in some other country and you get a random dog bite or some kind of weird stray animal bite, that is a trip ender. That is a come home and you need to be covered for rabies because that happens in other countries more than it happens here. The other animals here domestically that can have rabies include the list here. The skunks, the raccoons, bats is the most common risk animal. But there are a list of things here, including rodents, like the rat bite or the mouse bite, rabbits and squirrels that do not pose a risk for rabies and do not need rabies vaccination. Certainly anyone, there's the common scenario of the people walk into the room and the baby's in the crib and there was a bat in the room and they don't know if there was an exposure or not. The CDC recommends to cover that as a potential exposure for rabies if it's unclear because bats do have a high risk of carrying rabies. Rabies is a fatal disease, which is why we're generous with our coverage. It is fatal, especially if there's any symptoms that are present. So we're generous with our rabies vaccination if we think there's a potential exposure. And you see that there's a regimen here that involves immune globulin and the active vaccine as well. And again, the CDC has really, really good, easy to follow recommendations about rabies prophylaxis. What about bites and stings that we see? Really common injuries as well. Bees, wasps, the Hymenoptera class of things, and ants. Usually these are not a big deal. People have local burning and pain. We do know that about 10 to 15% of people who suffer these types of bites and stings have a large local reaction. They often come in because in the first day or so, it's really big and red. And that happens. That happens in about 10 to 15%. And that's not an infection. It's not cellulitis. It's just a more dramatic reaction to the antigen that's been placed there. And it doesn't also mean that they necessarily have a higher risk of going on to having anaphylaxis the next time around. There is a subset of those that will, but it doesn't mean that they're automatically allergic to bees and have to, the next time they get bit, they're going to have an EpiPen. Doesn't necessarily mean that that's leading to anaphylaxis. Usually we just treat these with ice, just supportive measures, over-the-counter pain meds, that kinds of things. How about spider bites? Interesting one. Remember that most people with the chief complaint of spider bite don't have a spider bite. Most of them have MRSA, and they have some kind of skin infection they think was a spider bite, but certainly there are people who do have spider bites and bring in the spider often for you to see, which is always fun. The black widow spider, we have to know what that looks like. We have to know a little bit about the characteristics of these different animals that do carry venom that we're concerned about. Black widow spiders are black, and they have this red hourglass on their body. And they're a little bit on the aggressive side. They can be kind of nasty. They, don't like to be disturbed. And certainly people will know when they've been bitten by a black widow. This does not happen secretly unless they have some kind of neuropathy or something and don't know. But certainly they should have immediate pain. And often what's interesting about the black widow venom, it is not life-threatening, but it can cause an interesting constellation of symptoms, including abdominal pain. And in fact, on the list of mimics, things that could look like appendicitis or an acute abdomen, is a black widow spider bite. It can cause nausea, vomiting, and abdominal pain. Typically, we treat these with ice and opioids and benzodiazepines, and the antivenom is really kind of controversial. Often the black widow antivenom can cause more problems than it solves, because most of the time these are not fatal types of bites, and the antivenom can create an immune reaction that may be worse than the spider bite itself, so a little bit controversial. Brown recluse spider bites. Brown recluse spiders are in certain parts of the country. They are reclusive. They are not on the aggressive side like black widow spiders. Not that black widow spiders are going around looking to bite you, but if you happen to encounter one, they're a little more aggressive than a brown recluse. They are brown. They have this kind of violin-shaped thing. They have more of a delayed pain, and they do have this, basically what we would describe as a volcano or a necrosis that occurs over time and causes this kind of characteristic lesion that often people think they confuse this with the MRSA. They can have systemic symptoms, including hemolysis and necrosis, things like that. We treat these typically with analgesics, debridement if needed. There's really no antivenom that's available, that's commonly available, and so we just do local wound care for these types of bites. Snake bites are something, depending on where you work, you might see as well. Rattlesnakes are in the family of crotalids. They're in the same family with copperheads and cottonmouths are all crotalids. Rattlesnake bites are a whole separate topic. You could give a whole long day course on rattlesnake bites and all the interesting things about them. But certainly the types of people who get bit by rattlesnakes, obviously it can happen while you're hiking, but it often happens in the setting of young, male, drunk, playing with snakes they shouldn't be playing with. That's the kind of scenario where I see this the most commonly. And often you have local effects from the venom. Now there are the differentiation between dry bites and real bites, and often if there is an ooze there, you could assume that there was some envenomation. That's probably true. What do we need to know about rattlesnake bites? Get a toxicologist involved. We don't want to IND these. We don't want to do fasciotomies. We don't want to do invasive things. What we want to do is give antivenom, and a lot of it, and enough of it. And that is really the key and supportive care for rattlesnake bites, is to not let a surgeon near it, because it's going to start to look like a compartment syndrome. And really, antivenom is the treatment of choice. And that's the end of environmental emergencies. Thank you.